Executive functioning, another caveat, just so you know, disruption of central control processes can result in impaired behavior even if the component process such as memory and intention are intact. However, research shows that people who differ on tests of executive function differ really about the same on other tests, such as tests for inductive reasoning and fluid intelligence, both of which decline in old age. So caution needs to be taken with any kind of neuropsych evaluations, whether in-depth or screening, so that you don't make generalized causation statements, right? Because there is some overlap with inductive reasoning and executive functioning. Right. Always be aware of age-related cognitive decline. Be aware of the norms. You know, what do the norms say? And most of them are age-related norms. So you're looking at the 89-year-old compared to other 89-year-olds. You know, not an 89-year-old compared to the 30-year-old you're used to testing, and the 30-year-old you're used to testing is much faster than this 89-year-old, and you're using non-evidence-based tests over there. So anyway, something to keep in mind. I just like this slide. I haven't been able to find it since I put it up there. I have no idea where I got it, but I've had it for years. It looks at the many different areas of executive function. And executive functioning, there's different areas of the brain, but most of them are your forebrain. The dorsal lateral prefrontal cortex is the area that regulates attention, control of cognitive activities, and working memory. The orbital frontal cortex is impulse control, regulation of maintenance of ongoing behavior. And the ventral medial prefrontal cortex, also sometimes called the cingulate, is for motivational states. I put these things up there because I've done years of study and classes and everything else combined for this class for you guys, and I thought as you're doing your testing you might come up with, oh, this guy has some problems with impulse control. You can put in there, maybe that part of his brain is damaged, maybe not. All right, so problems with frontal lobe dysfunction are many. You'll see people having problems with abstraction, problems with self-awareness. You'll see them having problems initiating, motivation. You'll also see them having problems with cognitive flexibility and impulsivity. So that's some of the things that you'll see with people with frontal lobe dysfunction. Now remember, as I said before, the first thing to go is the last thing to develop. Our frontal lobes are the last to develop, so our functioning in that area is the first to go. Also, most closed head injuries have to do with the front of the brain. So that's why we're seeing dysfunction there. Executive functioning pathologies are also many. You can have executive syndrome, which is really focused on disorganization. You can also have disinhibition syndrome, which is focused on impulsivity, and then apathetic syndrome, which is focused on disinterest. And all of these can be results of traumatic brain injuries. All of the different drugs have different effects on your brain. We'll talk a little bit about alcohol with regard to dementia, but yeah, the people who have long histories of meth use, they have more problems with impulsivity, emotional regulation. People with cocaine abuse have more problems with depression and getting themselves motivated. So yeah, different parts of the brain are affected by different drugs and the amount and use and duration and length. So. Okay, so the rule of thumb with drug use. After 2 years, 18 months to 2 years, the brain starts working the way it's supposed to. So if someone's been using 6 months, if someone's been using 16 years, I tell them, wait until 2-year mark. After 2-year mark, if you're still feeling the way you're feeling, depressed, no motivation, then you might have done permanent damage to your brain. That's when you should get on psych meds. Right? There's 2 schools of thought with regard to psych meds. One school of thought is, okay, they're giving up drugs, so we should immediately get them on a mood stabilizer because their moods are going to be all over the place. They're going to have a lot of withdrawal. They're going to have a lot of different symptoms, which will cause them to relapse quickly. So let's get them on a mood stabilizer so that they have that much more control. The other school of thought is, well, they're getting off of drugs. Let's clear them out. Let's don't let them have any meds or drugs or anything in their system for the 1 year to 18-month mark, and then see how their body naturally bounces back and regenerates and starts working. And then after that 18 months to 2 years, get them on psych meds if we need to. My personal belief is I belong to the second school of thought, namely because many people coming off of drugs, going through withdrawal, trying to get back on track, if you give them psych meds and they start feeling normal, they'll start using to get high. Because the psych meds bring them up here, they start using to get up here again. And now they found, okay, now I can use both of these to get much better results than I used to. But if they're in a controlled environment, meaning that they are in some sort of program, then one, it's up to the program, but two, they're going to be taken care of in an environmental setting, so they don't necessarily need the psych med. But that's my own personal